Are we live, Sam?
Yes, we are, Paul.
Good, we're live. Oh, brilliant, thank you. Welcome everyone, welcome to Governing Body for NHS Devon CCG. I'm Paul Johnson, I'm the chair of the meeting. Welcome, particularly if you are either watching us live or watching the rerun, then welcome. I won't go through necessarily introductions, but a particular welcome to Susie Leather, who's independent chair of the Devon STP, soon to be ICS, confirmed, which is great news. But Susie, welcome. I think you're going to be as much a part of our governing body as you can be over these next few months, this sort of transition period. We'll go through sort of formal apologies and so on in a moment, but one of the things that we always like to do is to make sure that we start these meetings by focusing on the reason most of us get out of bed in the morning and come to work, which is the population that we serve. And so we try and hear stories either from patients or public who have interacted with the services we commission, or from people who provide some of those services or some of the other services that people are really dependent on and really value. And that's where we are this morning. So Debbie Francis is joining us, and I'm going to hand over to Darren in a moment to introduce this. But Debbie is from the project. And it's a focus very much around young people and young people's mental health, which I think is particularly pertinent as we come out of this phase and people have been in that social restriction for a long period of time. And it's a concern that I know that members of the governing body have raised around people's mental health, and particularly young people's mental health, as a result of this pandemic. So Darren, if I hand over to you initially, and then on to Debbie. Debbie, welcome. And if we do ask any questions at any point or make any comments, please just start by saying who you are and what you do, so those people who aren't familiar with all the faces will gradually get to know us. Thank you.
Thanks, Paul. I think you've done it all. I think Debbie Francis. Debbie's going to talk to us today about mental health services from the perspective of being a parent carer. And I know Debbie's got an awful lot to say. All of it is really, really fascinating stuff and something we could all learn from. So Debbie, the floor is yours.
Thank you very much. So a little bit of confusion about what I'm supposed to be talking about, to be honest here. But I wear many hats, one of which is as a parent carer to someone who is now a young adult who has complex and enduring mental health issues. My daughter Jess has experienced mental health issues since she was 15 years old. She's now 20.
Sorry, Debbie, sorry, it's quite in case it's any of our fault. Can I just ask everyone else to go on mute? And then let's see if we can hear you any clearer.
Is that any better?
Yes, that sounds better. Yes, thank you.
Okay, I'll get a bit nearer to my computer. So I guess as a result of what happened with my daughter, or what continues to happen with my daughter, I set up an early intervention peer support project for young people in East Devon, which started in 2013. And although I no longer run it, it is still functioning as was the project now Headlight. It now operates in, I think, 4 towns across East Devon. Since my daughter's has been unwell, my interest in mental health, that's when it first started. And I now do a lot of work with the trust in terms of mainly around parent carer involvement and engagement with services, on the basis that carers are often very much left out in the cold when their child or a young person is affected by mental illness. So I think I'm kind of going to unpick things a little bit. I want to share with you something of the last few years of what has actually happened to me and to my daughter through access to services. And maybe then sort of with that explaining some of what my interest is and the work I've been doing to try and improve services. And you'll perhaps then understand why I'm so passionate about doing that. As I say, Jess has had mental illness for around 12 years. She has currently got a label or a diagnosis of emotionally unstable personality disorder, complex PTSD, and probably not surprisingly, severe depression. those are the current labels that people have attached to her. What we know in Devon is that we have very few certainly resources around, it seems, early intervention, appropriate community support, certainly a lack of a real understanding around management of personality disorder, which is fundamentally a trauma disorder. For the past 3.5 years, for most of that time, 3 years of that time, Jess has been hospitalised on acute wards, psychiatric intensive care wards, specialist personality wards, all of which have been out of area. She spent 3 years out of area in London, in Coventry, London, and London again. And most of those, all of those actually, have been through private providers, through Signet Healthcare. Unfortunately, Devon, 10% of all out-of-area bed days in England are from Devon, and we have just under 20,000 out-of-area bed days from Devon Partnership Trust, which is one of the highest in the country. My issue is there that out-of-area bed days are associated with delayed recovery, longer admissions, worse outcomes, and further trauma. And for someone who has a trauma disorder, having been carted around the country like a parcel, her condition is now far worse than when she engaged with services 3.5 years ago. We know that, I know that the CCG is supposed to be focusing on evidence-based and innovative practice and providing safe and effective services closer to home, and unfortunately that has not been our experience. Jess has been involved in numerous incidents in wards across the country, one of which in Signet Coventry, where she nearly died as a result of failings of care. And there have been 3 root cause analysis investigations into her care in the last 3 years through service failings. And I guess part of my frustration is that there are many evidence-based practices that have good results, I guess. That we know that things like EMDR, for instance, eye movement reprogrammed desensitization, and Jess doesn't even have access to that. DBT, which there was none in this county, she had to go to London for inpatient DBT services. There are so many things that have happened to Jess that have traumatized her. She has had 16 sessions of electric shock treatment, for instance, which every psychiatrist since that 2 years ago has questioned that shouldn't have happened. There have been blatant ignorings of NICE guidance around how personality disorders should be managed. My frustration is really what I have seen happen to Jess through the failings of services. She's had 14 psychiatrists in 3 years in 6 hospitals, and every single person has had a different opinion on how to treat her, where she should go, what she should do, where she should be, and fundamentally it would seem that nobody really wants her. So I guess, part of my frustration is I've stood on the sidelines watching this happen to Jess, and the way in which services engage or choose not to engage with carers is really destructive, as is the lack of early intervention support, which, despite people knowing how much evidence there is to support early intervention, it still doesn't happen. I know that in the last 3 years, Jess's care has probably cost close on £750,000, and yet I hear around resources, and that resources are tight, and I don't dispute that for 1 minute. But actually, what I know is that there is a misuse of resources so often. If I count the PQ, the psychiatric intensive care admission, acute, the electric shock treatment, the admissions through A&E, a 2-week stay on an acute medical unit in Exeter because there were no acute beds anywhere in the country, so she had to stay there. Paramedic call-outs, you name it. The costs are phenomenal, and not just the financial costs, the cost to Jess and the cost to me, before you then factor in the fact the months I've had off sick with trauma, having supported Jess through numerous suicide attempts, chronic self-harm at the highest level, and yet there is no carer support. So there is this frustration that, you know, when Jess is in hospital, I'm no longer deemed to be a carer. So I can't claim carer's allowance. I've had to be on universal credit. If Jess was in prison, I could claim an allowance to go and visit her, but I can't because she's in a psychiatric unit. So I've had to pay to travel around the country to visit her in various units because Devon doesn't provide adequate beds. And I know people will say that there are new units being built, but actually we've known for years that mental health services have been chronically underfunded in Devon. The work that I do, as I say, first of all, I set up an early intervention peer support project, which continues to support hundreds of young people every year who don't meet the thresholds for mental health services. I also now work delivering training across the trust, and I was delivering training yesterday for CAM's inpatient units about the young person's voice and the parent carer's voice in their care, because shared decision making should be something that we across the board should be focusing on. We should be focusing on more recovery oriented practices, and yet I don't see any evidence of that happening. On trauma informed care, and I don't see any evidence of that happening. We know that services re-traumatize people by not involving them in decision making, by having to retell their story, by not being collaborative, by you know, not being consistent. And so all of these things are things that I see that our mental health system actually re-traumatizes people on a day-to-day basis. But so I guess my work continues, and I'm currently doing a master's in mental health recovery and social inclusion. And I was also very privileged to be awarded a Churchill Fellowship 2 years ago, and have travelled to Australia and Finland to look at initiatives preventing the escalation and recurrence of mental illness in young people in Australia and Finland, both of which are far more innovative than we are in all sorts of ways, and are really prepared to be courageous in terms of the way they approach particularly youth mental health through use of natural resources, so being out in nature, through early intervention, through peer supported open dialogue, which again embraces all of the recovery focused, all the trauma informed approaches that I know would be most beneficial to people who are struggling. Much more, you know, around early intervention, working in schools to do more around raising emotional literacy, much more work with carers as an integral part of the care and support provided to children. It's not, in this country, it seems to be carers are an afterthought, and yet the way I see it, and all the parent carers I've met, and I ran a parent carer support group for 5 years, and I'm part of a national network of parent carers, and everybody says the same, that actually parent carers are sidelined, and yet they are a resource that is underused. I've met many parents who've set up their own parent carer support group, and there is one here in Devon, but she's done it just like I did as a parent. She raises all the money herself. The only support I get as a carer is through a charitable organisation that I'm fortunate enough that is attached to my local GP practice, but it's not funded by the NHS, and that's a trauma-informed counselling service for people who have experienced trauma. So for me, that's very appropriate. But these innovations are you know, grassroots organisations that emerge because people see a need, and yet my frustration with that is, like when I set up the project, I raised all the money myself. We were funded by Comic Relief, and now it's funded by Children in Need. And I feel it's really sad that on the doorstep right here in Devon, we have incredible services that are being run within the voluntary sector. And I know, because I've tried to get funding out of the clinical commissioning group, and it's like trying to get blood out of stone, and the complexities of the commissioning system means that actually on a regular basis these grassroots, really, really valuable small charities that exist and that are crying out to work in a more collaborative way with the NHS are sidelined. And you know, it is really frustrating, because I can see what needs to be done, but I don't see a willingness within services to really embrace what the voluntary and community sector can offer. So I guess, yeah, my story is a pretty desperate one. You know, it feels desperate because my battle with my daughter continues. As I say, she's now 27 years old. She is now back in Devon, living in supported living in Exeter, and 3 weeks ago made 3 more suicide attempts. This is my reality that I live with every single day, that I have to find a way to carry on living my life well and to support Jess and the rest of my family to deal with the trauma of living alongside someone who has fundamentally been failed by the system repeatedly over several years. And I would really ask that mental health services, or that actually NHS services more generally, become more courageous in terms of being willing to make changes. And I know that there is investment in mental health services at the moment. I know about the community mental health framework. I'm involved in this work. I'm part of the patient safety group for the Royal College of Psychiatrists as a carer representative. So, you know, I'm doing my bit to try and make a difference. And I would really like the CCG to meet me halfway sometimes. You know, it just feels like sometimes it's like banging my head on a brick wall. And I also know from people within the system, from staff within the system, that they are also failed by it, that staff working on inpatient units are tired and exhausted. Staff shortages are chronic because they are underpaid, they are overworked, they are under-resourced. We have healthcare assistants working on CAMS units who are paid minimum wage and have no mental health training. We have people with no mental health training supporting our most vulnerable young people in our community. And that is just wrong, because I know what they're having to deal with day in, day out, and it's not good. And I think if we keep throwing money at the high end, I agree that it has to happen. We need crisis care. But unless we start investing in those grassroots organisations that are playing a preventative role, we will never have enough money to meet this crisis of mental health in our community. And we know that in the last year through COVID, the numbers of young people impacted with their mental health has gone through the roof. There's been a 700% increase nationally in referrals to eating disorder units or services, and self-harm has gone through the roof as well. And I see this as just being the tip of the iceberg, because the fallout that we are going to see as a result of COVID on our young people is going to be long lasting, and we have to do something different. So thank you.
Debbie, thank you for your honesty, and also thank you for your drive, because I'm sure your drive made a massive difference where you felt the frustrations that other things didn't with your daughter, but also actually impacting on other people similar to you who are having similar struggles within their families. I am going to go to questions in a moment. I'm going to invite 2 people specifically to comment, because I think that the thing that seemed to drive you was the degree of frustration that you had with the statutory system, and particularly in Devon. So I am going to ask Simon in a moment, as our accountable officer, just to sort of reflect on that a little bit, and I think that would be helpful. And then secondly, coming from this is an ask about how those within the voluntary sector, and I know you're very focused on mental health, but I think it goes wider than that. How do we work and engage with them effectively? And that's something that has been top of Susie Leather's priority as independent chair of the soon-to-be integrated care system. So Susie, I'd just like you to reflect on what your ambition is around the sort of us being properly engaged and working in partnership with the voluntary organisations. But Simon, to you first.
Yeah, thanks, Paul. Thanks, Debbie. So I suppose the first thing I want to say is I'm really sorry for how Jess has received treatment and support or not in many cases, and for the lack of communication and lack of support that you've had as her mum and her carer. So heartfelt apology. It was a very difficult story to listen to, and many failings, errors, through lack of investment, lack of workforce, whatever it happens to be. It's not acceptable. I think in terms of how we support the voluntary sector and early interventions, we are just about to launch a national programme called the Community Mental Health Framework, which is very much about peer support, like I say, early intervention, working closely with the voluntary sector, but it's words. And I'm a big believer, and have said this before, that it's deeds, not words, that will make the difference. So what I'd really like to offer to you is, if myself and Jo, who I'm sure will introduce herself at some stage when she comes in, who's the director responsible for mental health and children's services, if we actually meet and talk outside of this forum, it's very difficult to discuss individual cases at a public board meeting. But if we meet and discuss some of the ideas you've got about how we could improve not just the care for people like Jess, but also how we can work better with voluntary sector and carers, because that really shone through to me, that we think we're doing okay with that. In fact, I think we get quite a lot of compliments from regional office that Devon is better than other places, but actually that story wouldn't hold that truth, would it? So I think there's a vast amount of improvement we can make, but we'll only be able to do that by talking to people like yourself and hearing those very direct stories. So again, very sorry about that, and we'll make sure that we do better for the next Jess and the next Debbie.
Thanks, Simon. Susie.
I come in. So Debbie, first of all, thank you very much indeed for presenting to us today and reminding us what the reality is really of being a parent of someone who has the difficulties that Jess has. So what I would say is that my sense is that finally the tanker is turning. There is a much better recognition, I think, of the frankly poor treatment that people with mental health, both adults and children and adolescents, have had for generations, really. And it's very troubling to hear that Devon is, nationally, in some respects, such a poor performer. However, I don't think that the tanker is going to turn fast enough unless public services engage with the community and voluntary sector much better than they have done so far. So for me, what that means, first of all, is the public sector listening, doing what we're doing today, really, and then co-creating the solutions. Because if you look back to when Jess first had problems, I guess you now, with the benefit of hindsight, probably have quite a good sense of what the right prevention would have been. And it would be extraordinarily helpful, I think, for those of us with responsibility for crafting public services, to have that wisdom and insight now, so we can start now to get it better for the future. But you also touched on how we strengthen the community and voluntary sector so that you have the infrastructure, so we can have the conversations together. So I think the funding of the voluntary and community sector is also really important. For the future, we're going to be having system-based conversations about this, but a lot of what's going to be really transformative is going to happen at place level. And so I would like to join the conversation that Simon has just invited you to. If I could be part of that, that would be great. But we need to have these conversations at the level of place, as close to where people are living their lives as possible. So where Jess is living now, it would be really helpful to know what are the things that she and the people she's living with need now. There's not a bottomless pit of money, so we will have to make extremely difficult allocation decisions. But I think, faced with the reality of what you've brought to us today, the first and best place to start is by having honest conversations and us doing more listening. And I thank you very much again for what you've told us today.
Thank you.
Thanks, Susie. I have got there's 5 people wanted to say something. So let's go for Joe and then to David initially first, please.
Thank you, Chair. Yes, thank you, Debbie. My name's Jo Turl, Director of Commissioning for Out of Hospital Services. So mental health commissioning fits in my portfolio, Debbie. So really, I'm not going to say very much because I'm going to repeat the sentiment from Simon and Susie. But I did want to take the opportunity to introduce myself to you. And so, you know, it's hard to sit here and hear that story and not be moved and to want to do something that improves services. So I'm just wanted to say hello and just to say that I'm really looking forward to meeting you soon, Debbie.
David.
Thanks. Yeah, I'm a GP in South Devon and I'm the Southern Area Clinical Representative. I think we just need to put our hands up and say we have not served this group of patients well. And actually, I do think we need to take responsibility for that. And I think until we recognise that we've had a systematic failure in the way that we deal with this, I think we won't make the sort of reform that we need. And I just wanted to say that these patients who have trauma-based problems are costing us huge sums of money. I can think of 2 or 3 patients on my own list who will have a contact with physical services every week. We'll be in A&E every fortnight. We'll see liaison psychiatry perhaps every fortnight and have yet another assessment from liaison psychiatry, but no intervention. And so inpatient stays, A&E attendances, GP attendances, liaison psychiatry attendances, but no treatment. And we are spending, and I'm not at all surprised to hear the sort of figures that you mentioned, but I suspect there's lots of other people who don't get the inpatient psychiatric stays, but are still costing us huge sums of money. And when you talk to DPT, they'll say that we don't commission the sort of services that we're talking about. And I just wonder if the first step might be to have a proper review of the evidence for what works in terms of treatment. And it may be that we need to be spending more money on, sorry, excuse me a second.
That's 10 chimes we have to wait for us, David.
Sorry about that. I need to be in a room without a clock. What I was going to say was that, for instance, the evidence base for DBT, and I think we seriously need to look at how much DBT we should be commissioning based on the evidence. But there's an awful lot of people out there who have trauma-based problems who are not being offered any treatment at all. And finally, I just want to say again that we need to recognise the value of carers, and particularly family carers, and the saving that they give to the NHS. So it's absolutely true that most of these people are very, very difficult to care for. And if it weren't for family members caring for them, the NHS would incur even more expense. So we need to be really clear that we are paying, we just are paying in the wrong place.
Okay, thanks, David.
Just had 3 mental health assessments in A&E in a week from liaison psychiatry, each time referred to the crisis team And the crisis team each time said they wouldn't work with her on the basis she was in supported living. So we go round and round in circles. So I bear out exactly what you say. Thank you.
Okay. Let's bring us, so there's Alison and Nick and Judy, and then I will try and sort of bring together all of the sort of the sort of sentiment that's been expressed, but also some of the tangible things that I know has come from Simon and from Susie, for example. Okay, so Alison.
Hi Debbie, I'm Alison Davis. I'm an associate non-executive director, but I'm also a social worker. And so it's really good to hear David saying that we ought to do more to support carers, and to hear you talking about hearing the young person's voice, because I think that's something we need to do more of. But I'm hearing my colleagues talk about changing systems, looking at longer term changes. I wanted to know from you, if we have someone who was in your position when Jess was a teenager, what is the one thing we could do in the short term that would support a family while we're making major changes?
So I'm going to put that straight back to you, Debbie, rather than going straight to someone else, because that's or whether you need a pause to think about what that might be.
No, I think, I mean, if we're looking at early intervention, the thing that even if a young person gets support, which is a rare thing in itself because of thresholds, the parent carers don't. So in the group that I set up, and now there is a group called Parental Minds in Devon, again, a voluntary sector group run by a parent. And those are the things that make the difference, because actually more than anything, what parents want is to meet other parents who are going through it, because there is a sense of terrible guilt and shame. There is a real stigma that exists if you're a parent of a child with mental illness from other parents, sometimes from family members. I'm lucky I've got a very supportive family. So we need to be funding support groups, peer support groups for parents, and psychoeducation, really, so that parents have an understanding of the challenges a child might be facing. So, for instance, it's really helpful to understand issues like self-harm and how to manage that better. It's really helpful to understand depression and anxiety. For me, it's really helpful to understand personality disorder, because then I can support my child. And that's been my take since Jess was 15 years old. I don't come from a background where we have a history of mental illness. So I knew nothing about mental illness when Jess first got ill. And I was crying out for information that nobody would provide me with. So I think there is a lot of evidence that if carers and families are involved, we get better outcomes for young people in terms of their treatment, get better engagement with services if families are involved. So young people are much more likely to stay in contact with services. So I think it's crucial that families are equipped with knowledge, with information, so that there is this possibility of shared decision making, because you can't make shared decision making unless you've got information to make good choices, because you can't make good choices if you don't have information. So I think that for me is that early intervention with young people needs to include families from the off. That's what's so great about things like open dialogue, because the integral part of open dialogue is the conversation exists with the family right from the outset. It's family and the network make decisions together, and you move forward together rather than treating the person separately. And then it's like, oh yes, this kind of family's over here that's in crisis too, and falling apart. But that somehow doesn't seem to be taken into account. So that's, sorry, long answer probably, but that's my thought.
Thank you.
Yeah, that's very helpful, Debbie. Nick.
Thanks, Paul. Debbie, thank you for a fantastic presentation. It was absolutely shocking, really, to hear some of the ways that your daughter has been misserved by Devon, and I'd like to add my apology to it. But could you tell us if there was one thing that you saw either in Finland that you thought, wow, that would really make a difference? Can you give us one lesson from those two health economies of something that you've never seen in the UK?
Well, I think certainly with young people, what I liked was, one thing. I mean, I think because open dialogue started in Finland,
Right.
there is much more focus on that, on the family, as an integral part, as a part of treatment. So I think for them it's quite an alien concept not to treat the family. So I think that's the thing that I got most. But I think in Australia, the thing that I see, particularly in how we care for young people, is rather than focusing on a diagnosis, it's like, what can we do to, like, a strengths-based approach? So actually helping, because I know all the young people I've ever met, and there's been a lot with mental health issues, who don't want to be labelled in this way. They want to, and having a mental illness is only part of who they are. So I think the things that I was most inspired is things like, and I know it's more difficult here, but wilderness therapy or nature therapy, things that get you outside. Because, one of the things that's happened to Jess is that she spent 3 years inpatient. That's 3 summers where she's had no time outside. The units she's been in have had no outside space. She's had no exercise. She's had no access to trees or nature or fresh air. And she has a chronic vitamin D deficiency as a result of being incarcerated for 3 years. So it's things, I think we have to think outside the box in terms of how we deliver services. And there is huge evidence around green care, around social farming, around all sorts of things that have better outcomes for young people than sticking them in inpatient units.
And given that we live in one of the most rural counties in the country, that shouldn't be too challenging for us to deliver on, should it?
No. And the other thing I would say is having services that go up to 25 makes a difference, because that transition at 18, when young people are still incredibly vulnerable and lots of other changes are happening in their life, like leaving school or going to uni or trying to find work, we cut services off at the very critical moment, and that really doesn't work. And both Finland and Australia, well, Finland go up to 28, but Australia much more, up to 25.
Okay. Thank you, Debbie, very much.
Judy.
Thank you very much. Debbie, my name's Judy Hargaden. I'm one of the non-executive directors too. I wanted to pay enormous respect to you for not only how frankly you've talked to us today, but also for what you've done over the last 12 years. I have one question to ask your opinion on, and whether it's an issue for us in Devon. I have a friend who was in a very similar position to you, and when she was trying to help with the care of her daughter, particularly after her daughter turned 18, she kept being told that as her daughter was now an adult, she could not have information, she could not be involved, her opinions didn't count. And so not just a not inclusion of the family carer, but an absolute rejection. Yep. And I have come across that in other situations where the NHS has become very nervous about how to manage carer input in decision making. It happens also in physical care, not just in mental health support. And I just wondered if you had experienced anything around that, or if you had an opinion about how we should handle that.
Sure, I definitely have an opinion about it. So, I mean, it is a hugely challenging area. And actually, because I was delivering this training with inpatient staff yesterday, we were discussing this very thing. And they said it's very difficult for them because they are in a position where they're terrified of getting it wrong. So that's the first thing that happens, is the clinicians are very scared of being blamed for something going wrong. But, I recognise and totally respect that there are needs to maintain confidentiality and consent when someone has made it clear. And Devon Partnership Trust state this very clearly in their charter for carers, is that you can always listen, and that's the thing that doesn't happen. So I'll give you an example. 3 weeks ago, when Jess made a suicide attempt, I was allowed to visit her back at the supported living, and she'd been put on 24/7 one-to-one observation. When I arrived, they let me see her on my own with her. And she said, well, I'm only on that for a week and then I'm going to kill myself. So that's not what you want to hear as a parent. I emailed her care coordinator. I usually respect Jess's confidentiality, but on the basis that she directly told me this was her intention, I tried to contact her care coordinator. I emailed. I got no response whatsoever to an email I sent. Very clearly, I was distressed and very clearly passing on specific information. And I emailed again 5 days later and said, I need to know that you've read this because she's coming off one-to-one tomorrow. She responded within a minute and said, yes, thank you. Not anything, not even an acknowledgement of, are you okay? Or thank you for this information. This has been really helpful. And that goes on all the time. So we are, at best, carers are tolerated, but at worst, it's active hostility. And it is a huge problem because I don't want to be involved in the minutiae of Jess's care. I don't need that, but I do need people to listen. And the root cause analysis or the incident in Coventry, if people had listened, that wouldn't have happened. And Signet have had to hold up their hands and admit liability to what happened to Jess. So there are times when I think there has to be, I think staff need better training, better awareness of the subtleties and the nuances of how to interpret the consent and confidentiality policies, because I get that it's a tricky area, but you cannot exclude carers because we have all the background information. And like I say, Jess has had 14 psychiatrists in 3 years, and information gets lost between hospitals, between different clinicians, and the one person who is consistent in Jess's life is me.
Yeah, thank you.
Debbie, thank you. I'm aware we need to move on, but we needed to give that enough time. I think, I mean, my reflection is that, you know, what I see from you is that there are things that have happened in Jess's life that we can't turn the clock back and change. But what I sense from you is you are using that experience to not only try and better things for Jess, but also to have a wider influence and impact on other people who will be facing similar pressures and similar illnesses to Jess, and other families who've been impacted like you have. So I think the opportunity that Simon has mentioned to actually help you to do that and to help us, I think is really valuable. You've talked about how do we get that parent support and that carer support right. You've talked about how do we actually work better in partnership with the voluntary sector. I think we've been challenged by a number of people within the governing body about what should we do differently, what should we do better, and that two things should influence that. One is from David talking about evidence base. Let's be clear and be sure what we know about the evidence base, and also that issue about talking to people like yourself with that lived experience, where there is a wealth of experience and advice that could be really helpful. And I'd like to see when Simon and Joe and Susie meet with you that all of that is brought into that discussion. We'll be talking a little bit later within the Finance Committee report. There is a section there around mental health provider collaborative, and it'll be interesting, and I think it'll be important for us to understand what are the opportunities that are within that, as well as within the community mental health framework, to try and to make sure that we do some of those things differently and do some of those things better. So I'd ask for Simon and for Joe and for Susie to feed back to us some of that learning that you get for that time spent with Debbie, and also from the other pieces of work that are underway, and some of the things that we as a CCG should commit to doing things differently in the way we commission. And then we'll need a dialogue with our providers about commitments, about maybe some of the things that they need to think about doing differently in the way that they provide services. And then what's been a really brave thing for you to do, to come and talk to us like this, but also what's been a really hard experience for you for many years, then maybe that can be a trigger to improvement, which I think would be an outcome that you would want to see, in my sense from what you've said, Debbie.
Yep.
So thank you everyone who has contributed. I will move us on. We may return briefly to this when we come to that finance report, but actually let's make sure Simon, Joe and Susie, if you can bring something back from us to us as a result of your discussions, that would be really helpful. Thank you. Thank you once again, Debbie.
Will someone contact to arrange the meeting, or how will that? Yeah, okay. All right, thank you very much for your time.
All right. Take care.
Bye-bye.
Okay, thank you everyone. Thank you for taking part in that. Sometimes things are difficult to hear, but important for us to hear and respond to. So thank you all. Let's move on through the meeting. So first of all, we've got welcome and apologies. So we've kind of done the welcome. I've got the list of apologies for the meeting here. Charlotte Burrows is still on maternity leave. Sheila McCormack and Simon Kerr are on annual leave. Gaynor and Appleby and Penny Harris are unable to join us. I think that's my full list of apologies. Nikki, if there's anyone else, then if you can let me know later on in the meeting, I'll make sure I add that to the list, but that's certainly the summary that you gave me yesterday. Thank you. Register of interest. Any changes or additions needed within your register of interests? Alison.
Thank you, Paul. I have notified in writing that it didn't get through in time. I no longer am employed by Torbay Council.
Okay. Ginny is on the line. That Ginny, things have to stay on for a particular period of time, don't they? But if we can make sure that's accurately articulated in the conflict of interest, is that okay?
Yeah, we'll do that.
Thanks. Okay. And Susie.
I'm aware that you don't have one at all from me, and I will make good. I apologise.
Okay, we should have yours. Annette should have a copy of yours from other sister meetings. Is that right?
She should do, but I will make sure that's updated.
Fine. Okay. All right. Thanks very much, Susie. Okay. And any conflicts of interest that are relevant to any of our particular items on the agenda for anyone? No, that's good. Thank you. So we go to our minutes from the meeting held on the 25th of February. And I'll go by the, in case people have got different page numbers, from the page number of the actual minutes themselves rather than overall pack. So for accuracy, we've got pages 1 and 2, 3 and 4, 5, 6, 7 and 8. We will take that as an accurate record of our meeting, our governing body, public governing body meeting in February. So we then come to the action log. There are 3 actions present. One was for Nikki, which was make sure that we have the CCG objectives as quarterly reports. That is on the draft agenda for April because Nikki and Ginny, you went through with that with me yesterday. So that is for closure. LCP locality structure document to be developed for the North and East as a test. That has just been sent out just a couple of days ago from Tim Golby. So Jane, I think that completes that task if that's been circulated, doesn't that?
It does, and I think Tim will draw on that if colleagues have questions when his item later for North and East.
Okay, brilliant. So that one was for closure, and then the last one was a briefing paper on MIUs and the current position of out of hospital urgent care. So we've got a verbal report today, John. I'll let you come in a moment, but my proposal would be that if the verbal report is sufficient for those who raise that as an action, we can close it. If there are unanswered questions, we may need to leave that open for something in writing at a later stage. But as long as you're happy with that, I say we revisit whether we close that action after that item later on today. Is that okay, John? Fine. Okay. All right. The next item is just for information, and one of the things that came out from the non-executive and clinician development and then sort of an action paper that has come from that about how we function is to see whether we can just have a summary paper that highlights what are the assurances and what are the decisions that governing body is being asked to make. And that's just that summary document there. So I won't go through it now, but please let me know if over the course of the next few governing bodies, if you find that useful or if there's anything we need to tweak on that. But the idea of that is just to help focus on our minds on some of those key things that we'll be talking about. Chair's report. I will take as read. There are two things I want to highlight. One is where we mentioned about the integrated care system. Since writing this paper, we have had formal approval from NHS England that we will be granted integrated care system status from April. And so, first of all, Susie, a huge thank you to you and also to Simon as interim system lead for the work that you have done to work with NHS England to demonstrate that we are a system of sufficient maturity to be able to operate as an integrated care system. And I think that sets us up in really good stead for the years ahead. And then the last thing is in item 6, just to highlight that I do say that this is we will be welcoming Jane Milligan at our next governing body. She joins us from the 1st of April, but this is to recognise that this is Simon's last governing body, not last governing body full stop, but last as our accountable officer. But I'm not going to say anything on that at the moment. I'm saving all the embarrassment until the end of the public meeting. So any questions or comments on that report? Alison.
There was the issue in I don't know why I've got an echo, sorry. But there was an issue in it about whether I could have approval to vote at quality assurance in Charlotte's absence.
Oh, yes, you were absolutely right. Yes. So this is a discussion that Nick and myself and Glynis have had with Ginny, and then I had a further conversation with Alison because Charlotte is, while Charlotte is on maternity leave, there is concern about quoracy around the Quality Assurance Committee. Alison has been part of that quality agenda in her associate non-executive role, and so we have had conversations with Alison, and she is prepared and very happy to step up into that voting role for us to gain from her experience and her wisdom, but also to ensure that the committee remains quorate. So I'm going to assume we're all in agreement unless I see any hands otherwise. Okay, thanks very much. Thanks for that prompt, Alison. Sorry, I didn't mention that specifically. Okay, Simon, over to you for your accountable officers report.
Thank you, Paul. So just a few things to note. As of the 13th of March, 500,000 people were vaccinated in Devon. So as of today, I'm just having a look at the date, 25, so 12 days later, we're now over 600,000. So just wanted to, my thanks to everybody that's been involved in that programme across the whole system. So local authorities, primary care, the hospitals, but particularly to Darren and his leadership of this programme. I think, you know, we use the word phenomenal or, you know, quite often. I think this really has been a phenomenal effort by everybody, but without Darren's leadership, we wouldn't have got to where we have. We know things are going to slow down over April, but you know, if Darren had his way, I think we'd have probably vaccinated everybody in Devon probably before now. I have to say, but you know, just to have got 2/3 of the way through our adult population is just fantastic. The supporting staff, item number 4, supporting staff and wellbeing. So those of you that were on the staff webinar yesterday will have seen this, but we've done 78% of our staff, so well in excess of 400 one-to-one wellbeing check-ins with our staff. Mainly those have been positive. So there's some things for us to work on, which Lauren Benham did a presentation yesterday to staff around some of the themes that have come out. And I think we're starting things like our yoga program next week. I won't be participating in that, but I think that's one of the things that people have been asking for, up to and including, I think, Paul, for us to think about in future, having at least half an hour break between 12 and 2. So having announced that yesterday, and then to see our governing bodies going across lunch break, we need to set a better example, don't we, for the future. And then item 5, so Devon Together newspaper. So people quite often talk to us about our social media, and our digital comms are excellent. And Sam, who's on the call with us today, is a great driver of that. But we also get asked the question about how do we reach those that haven't got access to social media. So we have done a community newspaper, a printed one, that's being delivered free to those areas where digital is not so commonplace, and places like supermarkets, etc. So a really good reach there, and reiterated some of the messages that we give on social media, particularly around vaccinations. It was in concert with DCC and with Devon and Cornwall Police, but it was driven by the CCG. So happy to take any questions, Paul.
Thanks, Simon. And Judy, like lightning with your hand there.
Well, I wanted to say I received the newspaper, and it's actually very good. And the advantage of written stuff is it hangs around for a few days and you go back to it. And so that's great. I also wanted to encourage Simon to try yoga. It really is very good. But the question I wanted to ask was, I know people are really anxious about what's coming out at a national level about vaccines, both about shortages of it and then some scare stories, but also we have done a brilliant job, and I agree, well done, Darren, and everybody else that's been involved in it. Are we doing things like where there's a cohort that is allowed, like the over 50s, are we encouraging through employers like the schools and police and fire brigade, those organisations that were wanting their staff to be vaccinated but didn't come up as in the high priority groups, but now we're doing over 50s, there must be quite a lot of, or perhaps I'm not right, I'm not sure if we're now doing over 50s, but just to raise, are we targeting some of those organisations, not just NHS and care homes?
I'll give Darren a chance to just take a very deep breath and give you the fulsome response. So the answer is yes, Judy, we are doing targeted work, but Darren can explain it much better than I can.
Yeah, thanks, Judy. And I think, for me, it is a real challenge, particularly around one about the workforce element, but 2 about the inequalities work. So I think, first of all, obviously, JCBI made a decision not to go further down any priority workforce groups. That said, we're working with the police, fire service, et cetera, to make sure that, particularly the over 50s at the moment, because the JCBI can be called in at short notice if they're still awaiting an appointment. And actually, we're seeing really good uptake in those particular areas. The other challenge that we're doing, so obviously today, is will be some more publicity next week, because it's more of a test of principle this week. So it's the first day of the bus, so a mobile vaccine unit, and we're absolutely going into a couple of our higher risk employers where we know previously they've had outbreaks because of inability to socially distance, etc. So we're absolutely now taking, and we'll be using April with our limited supply to really go back over the cohorts 1 to 9 to make sure that no individual feels that they've been left out, to make sure that we address any of the hesitancy issues, but also take the vaccine either through a mobile unit or through pop-ups to as close as possible to those particular areas. And we'll be taking the learning, particularly through there, and what we've seen in cohort 6, so those are the clinically vulnerable, which obviously take us down into the 16-year-olds, around how we see hesitancy is very linked to age, and how we then move when we're able to go into cohorts 10, 11, so that's the 49s and below, in May, around how we allow those individuals to access the vaccine as quickly and as easily as possible, because it's going to be slightly different to the mass sites and the primary care that the cohorts 1 to 9 have seen at the moment. So you will see a slight shift in our model to very much address the area that you're asking about, Judy.
Thank you very much, Darren. Well done.
Thanks, Darren. John. You might be on mute, John.
First at the public meeting, I do apologise, Chair. So thank you, Darren. I think it's been a fantastic effort, and I think we all recognise that. Can I an observation from the northern area, and I expect it's the same all over Devon, is that as we've come down the age groups, the age bands, there's been a reduction in the uptake of the vaccines. As we get, and you just mentioned a very sort of strict cut-off date for when we can start and stop, or certainly start the bands 10 to 12. Is there a risk that as the uptake reduces, if we adhere, if we are strict with our bans, we might risk wasting vaccine?
Thanks, John. I think that's an absolute fair challenge. I think as it stands at this moment in time, it's been a real area that I'm monitoring on a day-to-day basis. I think, as you say, we are heading now into our last week of high vaccine supply as we then move into the first week in April. As it stands at the moment, we will be in a position that gives us pretty much the numbers that we need for cohorts 1 to 9 with minimal wastage at the moment. Yet we are still, bearing in mind we're at over 600,000 doses, we are within 0.2% wastage of vaccine across the board at the moment, which I think is an amazing for any programme. But absolutely, this is something that I am monitoring on a day-to-day basis at the moment. I have programme board at lunchtime today, where again we will be monitoring particularly our short-dated vaccine to make sure that not one of those doses goes to waste.
Thank you.
Great. Thank you, Darren. And thank you, Simon, for your report. So no further questions. So we will go on to item 8.1. And Jane, that's for you, isn't it? So the recovery and transformation document, and we take your paper as read, so it's sort of highlighting any key points there, and then it's open for questions.
Jane? It's actually for John, sorry.
Yes, yeah,
yes. Oh, sorry, John, it's you. Apologies. Sorry, John.
I'm just taking a moment. Okay, thank you very much.
To rename yourself.
Yes. Well, we work so closely together. I'm sure Jane would mind picking this work up for me. Okay, so in terms of restoration of in-hospital service, and I'll stress that word, restoration in this context means returning to activity levels as similar to as last year. So it's not around performance improvement, it's clearly around recovering levels of service. So I'll just take the paper as read, but I think there's a couple of areas I think are worth reading actually. But just in terms to introduce this actually, in line with the December spend review, Devon continues to restore non-COVID services. In order to maximise that restoration, as we have nationally, Devon has agreed to aim for top quartile performance in a number of areas, and those are ophthalmology, MSK, and continue to improve restoration in diagnostics and cancer. To support recovery, we are calling upon national best practice through the GIRTH programme, fully engaged in the Adapt and Adopt programme actually, and locally in terms of our evidence-based work around the intensity gradient. So I'm asking the governing body to note current position and to support the actions to recover. So very briefly, in terms of elective recovery, in terms of RTT, the area I'd like to focus on in terms of is the weekly meeting of surgeons and managerial leads we have actually to review the very, very current Devon position. Brilliant engagement, some really good plans coming in place, not just in terms of what I'm dealing here, but the opposite requirement to look at 7-day working, three session days in order to recover this. But we have set a number of areas of best practice which are focusing on in ophthalmology, cataracts to deliver eight per session, in orthopedics for prem hip and knee, moving to a significant proportion of day case, in urology a number of procedures basically, again that'll move to day case, upper GI and to lap chole day case greater than 80%. In terms of outpatient activity, I think it's really important to recognise the speed at which services were adopted in terms of your attend anywhere platform. absolutely fantastic. Right from the beginning of COVID, actually, this was used as our main delivery mechanism for outpatient activity. Although it also has been noted basically that although in terms of restoration of services, Devon has been recognised as recovering the greatest number of outpatient appointments, we are lagging behind in terms of the use of video, phone, non-face-to-face consultations. And we have an outpatient steering group which is focused on this actually, but I said it's really critical we get to that 20% of digital outpatient activity, as that's one of the gateways to the elective recovery fund actually. So plans in place, but I said some resistance, I wouldn't say cultural resistance to it actually, but if we look at the figures I've shown you on page 5, the reason why Torbay are lagging behind is not the willingness to do this actually, but there is still a space requirement to undertake non-face-to-face activity actually. That's where that trust is particularly struggling. I think in terms of diagnostics, I think again, there's been an incredible amount of focus on diagnostics in Devon actually, and again, in very difficult times. Now, no other area I think has seen the impact of actually of COVID search, both in terms of the need for PPE, etc., but also staff moved into other areas of work actually as the COVID phases got more challenging. But for endoscopy, which again is probably the highest risk area actually, there are some areas of work that we've put in straight out of Adapt and Adopt. So again, that's really important in terms of looking to the national evidence around this. But we've supported restoration by a standardised triage of non-2-week pathways that are in place based on clinical risk. So the use of fit testing, and fecal calprotectin actually have been used prior to any decision in terms of whether an endoscopy is used. Actually, that's made a significant improvement in terms of available capacity actually, and this will continue into non-COVID times. I think also the use of the Nightingale. It was absolutely key pre-COVID. Actually, we'll very soon be up into in full swing in terms of the restoring CT, MRI, ultrasound, etc., etc. We have plans to increase that actually in line with our work around community diagnostic centres, which will focus on imaging, endoscopy, cardiovascular imaging, and phlebotomy. I think in terms of cancer, the one thing I'd like to point out is again, there's been we have done our very best and we have achieved actually in terms of access to urgent surgery and diagnostics throughout the COVID period actually. But one urge we have now is actually we've now got a single system-wide weekly 2-week wait summary that we use to identify if any particular tumour site is seeing referral rates at variance to what we would expect. So rather than just waiting to see the national data, actually on a weekly basis, if we're seeing an increased rate of referrals or reduced rate of referrals, actually we know about it the Monday after the week in which that is seen actually, and that allows us to put actions in immediately, as I said, rather than waiting for the national data, which can be 1 month or 2 months after that. I think a good example or two examples are when we saw increased 2-week wait endoscopy, we immediately were able to divert a patient to the independent sector, or when the rates of 2-week wait were identified as not recurring as expected for the lung pathway, we delivered a focused media campaign to support patients contacting their GPs. So I'm just highlighting a small number of areas of importance basically, but happy to take any further questions or challenges.
Thanks very much, John. And so the purpose is to try and to ensure that governing body is briefed on what we're doing and to try and gain the assurance that that as a commissioner we are doing all we can to try and tackle what is quite a phenomenal ask of the system as we come out of COVID on the level of demand that is there. So thank you. Lincoln, over to you first.
Thanks, John. Very informative paper, and particularly around the surveillance so that you can pick up issues and act quickly. I wondered to what extent you've been looking at some of the markers for waiting times and some of the other indicators against things that are markers for inequalities, such as to what extent do you know the variation around people with LD, BME as relevant socioeconomic deprivation, and whether that is giving you a lens? I was at a meeting, a national meeting yesterday, where certainly that kind of approach was picking up that the averages might look good, but there were some groups that we know traditionally, even before COVID, and whether that's something that we need to have eyes on. And secondary, how do we use some of the really good engagement that we've done around vaccine uptake and targeting some of these groups that have traditionally had issues with access, and how we take that learning to help us to restore for some of the groups even faster?
Yeah, just right at the beginning of COVID, we recognized that exactly what you described was going to be an issue. So in order to understand that issue, actually, Claire Hooper, our elected lead GP across the system, right from the beginning of COVID, and she's almost finished the paper now, has been undertaking a brilliant piece of work actually in understanding the impact of COVID, particularly on inequalities. Now, access to cancer services and elective surgery is part of that. So I said, rather than preempt her, what is a very complicated and very accurate piece of work, basically, our plan is to bring that paper to the governing body in due course, actually, which will identify both how we've identified need and what we're doing about it. Okay.
And John, do you have a rough timescale of when that would come to governing body?
So I've got my timings in terms of the out of hospital urgent care strategy that wrong last time, Paul. So can I just come back to Claire and confirm that actually, just to make certain of that?
That would be great. And then if you can liaise with Nikki, and we'll make sure that that's
it's certainly, if it's not next month, it'll be the month after that. But I'd like just to confirm that with her.
Thank you.
Yeah.
Glynis.
Yeah, John, thank you very much for a very comprehensive paper. I just wanted to ask whether in terms of the restoration programme, the exhaustion, stress of staff has been factored in, because we know that people have been, working above and beyond. And there was a lot of talk, a few weeks ago about that being recognised in this restoration programme, so that it was reasonable and gave people time to recover.
So, Glynis, I think that's absolutely critical. And I said, I'm very pleased to be able to say that the answer to that is broadly yes. So, for example, in terms of restoring the day case unit in Torbay, it probably could have been pushed a week or two earlier, basically, but allowing our staff to recover from that. And again, I think the teams in the Acute Trust have been really good at protecting their staff in that. That absolutely has happened. Speaking only yesterday to Phil Luke from RD&E, again, the importance of allowing their staff to recover before they return their elective work and their orthopedic work. That rest time broadly has been in place. But we can't speak for the entire hospital, actually, but certainly those areas and those clinicians actually who've been under particular levels of workload and stress, actually, that has been happening.
Okay, thank you.
Nick Ball.
Thank you, Chair. John, on the section about outpatient activity, you say under digital technology and optimising virtual appointments that we've set a target of 25% of first appointments, 60% of all follow-ups.
Yeah.
Presumably that's a trust-wide target, is it?
So it's a national target.
Oh, is it? Right,
and while a target's a target, basically, while it's been a really, really good thing to work towards, it becomes, and I said, in terms of it becomes increasingly important, the fact that this is probably going to be linked to the elective recovery fund. Yeah. So I said we have some work to do, but it's a national target on a Wednesday, every Wednesday morning. Actually, we see how we do against the region and the nationally. So I said it's been in place for about a year now, a year.
So my question is the recognition within that between different specialties, it might be more or less difficult to do face-to-face conversations?
Yeah, absolutely. It's at the highest level, actually, in terms of the aggregate position across the trust.
Okay, great. Thank you.
And John, just on that, there is, Torbay excluded. We're there with on that ambition with first outpatient appointments. I think it'd be great to exceed it. but actually there is that's a marker of success on that particular element that you're demonstrating. So that's definitely a positive news bit that's embedded within here. So that's really good. John Walmsley.
Lovely, thank you, Chair. So John, really on the same topic of digital technology, and we are not restoring old ways of working where we're restoring services. So it's really great that we're hitting that target of 25% in quite a few areas. Are you exploring the unintended consequences or how robust things are further down that referral pathway? And what I'm thinking about is there's a potential blurred area between an outpatient referral and advice and guidance. And it may be that after one video consultation, a consultant feels that actually this patient requires a test and I need not see them again. Do we have clear protocols that put responsibility for the tests, for instance, and following up those tests clearly within the secondary care arena, where the expertise lies, and that there's a clear protocol for how we hand back patients or how consultants hand back patients to GP follow-up?
Yeah. So, John, I can only base my answer on my experience and feedback from both GPs using the service and our clinicians in secondary care. That hasn't come to me as an issue. Now, through your own practice, if that's something you come across, I should be very happy to look at that. But that hasn't been raised as an issue.
Well, we know that referral numbers have been low during COVID, and I think everybody's slightly anxious that there may be a ballooning of referrals and activity, and with that may expose some of the issues. So I'm really pleased to hear that hasn't happened yet. Advice and guidance is probably the way forward for many of these patients, where as the medical world becomes so complicated, GPs need advice and guidance on how to look after patients. So I think if you haven't picked that up, then that's great. Can I ask that your work stream is closely linked to the primary care commissioning work stream as well, so that any potential problems that may cross those areas are discussed in a joint manner?
Yeah. Okay. Well, we'll do that, but I'll certainly try and enhance that on behalf of you after this conversation, John.
Love it. Thank you.
Yeah.
So just John, on that, you've got a steering group and you've got a GP representative on that.
Yeah.
I wonder whether if you can, we don't need names at the moment, but if you could pass that name on to John. John, I wonder whether you have a conversation with that GP about making sure that they are able to express any emergent concerns and they've got somewhere to take those concerns if necessary. And then we can have a degree of confidence that's being held within that GP's role within that committee.
Yeah.
Is that okay, John Finn?
Great, that's ideal.
Yeah. Okay. Thank you. Graham.
Thank you, Chair. My question is also about digital technology and virtual appointments, John. I think we're all agreeing that the move to this is a good thing. As you said, it links to the elective recovery fund. It's more productive for consultants. It's more efficient for clinics. But those are all organisational reasons for doing it. I want to be the patient voice this morning and ask, what is the assurance that this is actually better for patients and popular with patients?
Yeah. So, Graham, just two things. If at the beginning of a patient pathway, if it's found that a patient isn't suitable for a non-face-to-face consultation in terms of in secondary care, that is changed into a face-to-face, and all along that pathway, that's recognised that doesn't suit that individual patient. So I said right at the beginning of this program, actually, we needed a default position actually that if someone either they haven't got the IT in their home or haven't got the IT skills to work this, if that's the case, that is removed from their further care. Now, to date, in terms of feedback through our outpatient program from patients in terms of use of it, it is largely very positive. They not having to travel sometimes long distances to an acute hospital has been really, really welcome, particularly around follow-up. But I said, no, we'll need to do further work on it. As I said, there's no question as this becomes mainstream care. It's also been part of the work that Claire Hooper has done in terms of access to digital forums in terms of patient care, the impact on patients is actually, so it is constantly under review. But I said probably really important at the beginning of a patient's pathway, if this is not suitable for them in their review, basically they default to a face-to-face pathway.
Thank you, John. I absolutely accept that it means that people don't have to travel and trouble with parking or public transport. But it would be good to see some evidence.
Yes. Okay.
Feedback from patients.
So if I can take an action to come back in due course when we have that evidence, either positive or negative. Yeah.
Thank you.
Susie, I know you were next, but Andrew's put his hand up. Andrew, was that a point?
It was directly related to this point.
So do you want to come in next, and then I'll bring Susie in then?
Yeah, thank you, Chair, because I think Graham's point's a really important one. So we have done some engagement, Graham, using our citizens panel around support for digital consultations, and it is largely positive. But there is, in essence, a small bit in there, which I know is at the hub of your point. For people who can't, we're working with Healthwatch, for example, to try and do some support and training for people to access new technologies and digital. But as John said, if that doesn't work, then the default is face-to-face appointment. But we're happy to share some of that engagement work, Graham, with you.
Great, thanks, Andrew. Susie.
Mine may be slightly superfluous now. I mean, there has been some feedback to me from primary care of unhappiness about the way that secondary care is sometimes putting burdens on primary care for which primary care isn't getting resourced. I think it's a particular issue in phlebotomy, but I think there's a piece of work that's going on to sort this out. I do think, following Graham's point, I think it needs to be very clear to patients, you know, who is in the lead. So where is the clinical leadership on looking after them at any one point? Does that rest with their GP? Does it rest with the consultant or a more junior colleague in the acute system? And my second point is that I think we just need to be cognizant of the impact that this all might have on inequalities, because there will be access issues which mirror some of the inequality issues, or which just reflect the inequality issues. So I think we just keep an eye on that. That's all from me.
Okay, thanks, Susie. And from the primary care perspective, again, if we make if we make sure that the GP on that that group is aware of some of those concerns and has a route through to try and raise them, I think that will be helpful. John, I don't know whether you want to come back on the inequalities. I think it echoes some of the things that Lincoln was highlighting as well in the first question.
Yeah, I said it's most certainly covered in Claire Hooper's work. Actually, access to care via a digital forum has been one of the huge leaps forward in terms of as a result of COVID, basically. But there have been implications of that actually, and that's covered in Claire's work.
That's great. Thanks very much, John. Ginny, I'll let you come in, and then I've just got a couple of comments for you, John, and then we will move on. Ginny.
So I was just going to add to that, as part of the System Health Inequalities work stream, there is a specific work stream around digital inclusion, which is about making sure that we, on an ongoing basis, monitor those services. There are issues at the moment about getting the data that we need to do that, but that's very much a key part of that work, so that we can make sure that we look at new services, but also on an ongoing basis whether people are getting the access that they need.
Okay, thanks, Ginny. That's really helpful. So, John, a couple of things. One, I think is really positive. If on page 6 of your report, the middle section there describes at least 3 elements of cross-organisational system working to try and tackle some of these issues. And I think that's really positive to see that in there. I think that is, some of those integrated care system principles are starting to filter through to some of the actions that we're seeing within the provision as to how we're overcoming some of the challenges we face. So I think that's a real positive to lift out of there. I do want to thank you and the team for all you're doing. There's a huge amount of work going on in here, and I want to thank you for that. I have one question, which is on the second page. You talk about the national best practice around particularly some of those surgical procedures, but we don't have a snapshot of how far off from that we are, and therefore how big a piece of work that is. And then my second thing is, this is a snapshot of a very moving dynamic picture, and given that this is going to be so important for our population and for our commissioning, at least over the next 12 months, a date for coming back to assess progress against some of these ambitions would be really helpful. So it's just a sense from you as to when that would be appropriate, and at that time to see, particularly around surgical interventions, where we are compared to our ambition would be quite helpful.
Yeah. So we're now from yesterday, we're now benefiting from Suzanne Tracy as the chair of our elective board. So that brings with it many benefits. Certainly, even further system work, and effectively one of our system chief executives now leading this work. One of the actions we agreed yesterday was, as part of the demand and capacity work we're doing for 2021. Which is we will overlay in a sort of waterfall the impacts of all of this work. So I said, if our demand and capacity is showing that we're 17% out in ophthalmology, what is the impact of this surgical work on reducing that gap? And I said we intend to have that work done by June. So any governing body after that, actually, I think would be a good time to come back and update on that process.
Okay, so can we put a marker in on the forward planner then for July for that to come back, because that will be wider than just this, but it'll also help us see where we are on this programme. That would be really helpful.
Yeah.
Thank you. Thank you very much, John. That's really helpful, and actually a really good paper that is concise but articulates very clearly what it is we're doing. But don't go away, because 8.2 is you as well. So minor injuries units.
Okay, so a paper's not available today. I think after conversations with the exec, we do recognise that a paper is required, but that paper needs to be a combination of the strategic position on out-of-hospital urgent care, which is my responsibility, and the proposals from the LCPs of how they will respond to that. We expect that'll take up to 2 months to do. But I just thought I'd brief the governing body actually in terms of that work, so they recognise that it isn't that this won't be available. It's just that such is the robustness of the work actually that it'll take a bit further. So this organisation has put a lot of energy, time and commitment into the commissioning cycle. And I think this is a piece of work that I'd really want to follow that completely. So thus we've a significant piece of work been undertaken currently to identify the size and nature of the urgent care need among the Devon population currently, and also looking forward into the next 20 years. The purpose of that is to, in the context of this work in terms of out-of-hospital urgent care and MIUs, is to develop recommendations on the future shape of community care in Devon, which to consult with the public and stakeholders. Now, those proposals were based on a robust evidence base to ensure that the public and other stakeholders can be absolutely assured that the system's plans are based on a factual understanding of all relevant factors. As it says, so the work is been driven by a number of factors, 3 of which are the obviously requirement to implement the national specification for urgent treatment centres. There's also a real need to review the current community urgent care provision, taking into consideration those MIUs that have been closed either during or prior to COVID pandemic due to staffing. And the third sort of factor is that we need to review the current minor injury laws for general practice in this area, which runs in parallel to this work. So if I said, again, apologies for the work not being complete, but I said it'll take about a further 2 months to complete the work as I have described.
Okay, John. So what I'm going to do for the sake of time, Graham's come in, so I'll take a single question. But what I might ask is that actually we make this. So where are we now? March. So for June's governing body, so you've got the 2 months and then time to submit the paper. If we put in for June's governing body to come back, we'll leave the action open until then, and then we'll make sure that we create enough space to have a proper discussion around urgent care. But Graham, I'll let you come in on this one.
Thank you, Chair. John, I'm really grateful that you're doing a big piece of work on this and you'll bring a report back, and it does sound quite a big piece of work. But I just want to go back to why the question was raised originally. We've had a number of locality reports over the last few months indicating that MIUs were closed for a period because of staff shortages or COVID or whatever. And my question at the last governing body was, what impact is this having on other parts of the system, on GPs, on A&E and elsewhere? And can we just make sure that that sort of short-term immediate impact on other parts of the system is not lost in a wider review of the future of MIUs?
Yeah. So I think that's why I particularly mentioned the need to take that into scope. So because it is, and I would say in terms of the impact on the system at the moment, our systems have alternatives in place. So let's say for the North Devon MIUs where they have been closed prior to COVID, general practice is now taking on that work in a funded way. So it's not that we've just left a commissioning gap. No, we've been given very strong messaging to the public actually to only attend hospital and it is absolutely necessary. Now, taking away MIU services isn't really in line with that. Thus, we negotiated with general practice in the north actually for the areas around Ilfracombe and Bideford particularly actually, that they would take on that function until this work complete.
Thank you, John.
Yeah.
Okay, thanks, John. So we look forward to a more in-depth discussion around this in June. Thank you. Okay, 11 o'clock. Let's just take 5 minutes for people to stare at something that's not a screen. Well, it's 11:03, so 11:08, come back in and we'll start promptly at 10 past. Okay.
cold, John. Microphone.
I am. I don't normally feel the cold. I really don't. Like I could wear a t-shirt and -10 basically, right? But maybe my blood's starting to get old.
I expect the chair will be back shortly to.
There we go.
There. Microphone, Paul.
I can't do things quite as quickly when I used to be able to do when I was a younger man. Right, Tim, you are with us. Excellent. So everyone's coming back in, which is brilliant. Hopefully people stretched their legs and made themselves more comfortable. So we're on to item 9, which is our locality local care partnership reports. And as sort of we've described on previous governing bodies, our ambition is to really focus on 1 or 2 of these for each governing body. We'll receive the reports, and the reports are the same that go to the partnership board of the STP, and we'll have them all present for information, but we will have a particular focus, as I say, on 1 or 2 of them. So Tim, thank you for joining us. So let's take the South and the Plymouth ones as read, and let's spend a bit of time focusing on Northern and Eastern. And Tim, I know you've also circulated the sort of the governance structure around both of those. They won't be available for people who are watching because they didn't go out in the board packs. So what I'll do is I'll do my best when we come to them to see if we can get them up on the screen, at least for a brief period, so people who are watching from outside the CCG can reference them. But Tim, over to you to bring out. We'll take it as read for your reports, but to pick out some of the highlight elements, and then particularly around those governance structures. Thanks, Tim.
Okay, thank you. Good morning, everybody. So what I'm going to tend to do is that you've read the reports, and it's probably just worth reflecting on those governance structures that Paul will put on the screen. It's early days for local care partnerships, so I wouldn't want you to think that these are developing and emerging. But Paul, if you'd like to stick up one of the PowerPoint slides, they are very similar across the East and the North, slightly different language in different places. But our local care partnerships are essentially collaboration of people working in the health and care and wellbeing system to achieve more for the population than otherwise be the case. We have 3 elements to our local care partnerships in the North and the East. We have an executive group, and on that executive group sit the chief executives of the key provider trusts. This is the Northern Local Care Partnership. It's very similar in the East. So we have an executive group on the left-hand side there that has met 3 times now. That has the leadership of NDHT, the CCG. Simon is in attendance. It has the Director of Adult Social Services for Devon on that group. It has a primary care representation to be arranged, and Melanie Walker from the Mental Health Service. That's met 3 times, and it's beginning to set direction. It's in terms of reference, those documents I sent, and is beginning to ask the right questions of the other parts of the local care partnership. Intentionally, as I've said before, this is a circle so that it's a iterative, ongoing process. On the right-hand side there, and Dr. Walmsley may want to add to this, we have the Northern Integrated Delivery Group, and we're in the process of sharpening that up a little bit to focus much more on delivering the sorts of things that the executive group are saying around health and care. So we'll have a clear work programme. It will look at performance, and we'll report into the health and care executive group about those areas that we do well on, but particularly those areas we don't do so well on, with some corrective action plans. And the third and very important part of our partnership is the One Northern Devon partnership, which is Dr. Walmsley chairs this particular group, and it meets and it has a very much more specific focus around those wider elements of health and well-being. So what you get in the Northern report is a bit of an update from those groups. So you'll see in the Northern report that we're talking about the 3 or 4 work streams that the One Northern Devon is focusing on, which are just coming to it now. Health and well-being, safe, clean and sustainable places, economy, employment and skills, and health and social care delivery group. So we're trying to report on what goes on there. What you have in Northern Devon, of course, is the One Northern Devon branding, and each market town in One Northern Devon has its own One Northern Devon element, and that group is working with a range of stakeholders in the various towns to identify those priorities. And One Northern Devon has a range of projects that work with some of those, and they're described in the report. So I think I'm probably going to stop there, Chair, when it comes to Northern Devon, because it allows the best richness, I think, is in the conversation. You can see we've tried to put all the information together. Just referring to your previous conversation, really, that John was talking about minor injuries units. That's referred to in the report about some of the work that went on, and the conversations between the trust and the relevant primary care practice to make sure that the MIUs were staffed and supported. So we're beginning to work as a system rather than as a commissioner and a contractor, but plenty more to do. My assessment would be in the north that we've got a really good One Northern Devon partnership, which has got a strong focus on some of those wider terms of health and well-being. We've got a bit more to do on the delivery group and sharpening up some of those performance areas. So maybe if I stop there, Chair, and take any questions that people may have about the north.
Yeah, so firstly, John, let me invite you in whether there's anything else that you want to add.
Yeah. So thank you. So as Tim said, I chair the One Northern Devon bit, so that's one of the legs of our LCP stool, I suppose you could say. And I was just thinking this morning when we heard from the distressing story from Debbie about how she wished that the statutory organisations worked more effectively with the voluntary services and with communities. And I think that is exactly what we are seeking to do in One Northern Devon. We're looking to break down the barriers between organisations. We do try to have, use the phrase trauma-informed conversation. So actually, rather than us telling people what they need, we actually say, well, what's important to you? What would help? So those phrases like making every conversation count and having a trauma-informed conversation are so valuable. And when we heard Debbie talking and pleading that we could have early intervention, maybe even some societal changes around mental health, and I suppose if we take it to a less statutory thought, it's well-being. So if we can address some of the well-being challenges that we're going to face, certainly coming out of COVID, I think we can do our populations a great deal of support and good. So that's really what One Northern Devon is about. And I think I've referred to the concept of us being rather like a Marmot group. So I'm sure people have read the Marmot report, which is from 2010, and then there was Marmot 10 years on, which is 2020. And that does talk about health being more involved in housing and education and employment, because all of those things actually help somebody's well-being. And we all know that when those things go wrong, actually the NHS picks up the pieces. So I'm really keen that actually the NHS is able to have a voice and a view in all those other areas, because it's about people's quality of life and their well-being. And if we get that right, then we can be of great service. And the final thing I'd say is she also mentioned about the natural environment. So we have a close link with Natural Devon and with the North Devon Biosphere. And we have a very active program, as you'll see in the papers, around active cycling and people getting out and getting into the natural environment. And we all know how we feel better with that. So I think it's an exciting time. And I'm looking at the papers around the ICS and the idea of an ICS. We can see that the NHS and in the highest echelons of our governmental process, they are getting this concept that actually health is more than just medicine. It's more than just medicine. And I think if we can make sure that we as a CCG focus on that, and that LCPs focus on that, along with all, of course, the health delivery, social care requirements, and all our statutory markers, if we actually pay further attention to that arena, I think we have the potential to actually change our population's well-being. And I find that pretty exciting.
John, thank you very much. I'm just looking to see if Hands are coming up. James, you first.
Thank you, Chair. Given the success of One Northern Devon, and I'm a keen member of One South Malton, so my town group, and I sit on that both with my CCG hat, but also Recovery Devon hat on as well. Given the success, is it something that is replicable elsewhere in the county? I know we have other groups across the other localities, but is there any mileage in having a One Southern Devon, a One Eastern Devon perhaps, or One Brixham? I don't know. I know those areas have their own groups, but would there be some benefit in having or marketing it as a one group across Devon? And also, given the success, is it worth us sharing the model or the approach with other CCGs as something that they could learn from and adopt? I see John's got his hand up.
Yes, thank you, James. That's a great question. The answer to your question is yes and no. And why I say yes and no is one of the strengths of what started as One Ilfracombe in 2012 and One Northern Devon is it's been a bottom-up organisation, and all our communities have been bottom-up. So we have not been directive or instructive about what they should be doing. We've said, actually, here's an example. It's really up to you how you want to do it. And we look at what we're developing in Holsworthy area, where it goes across the border to Devon, into Cornwall. We didn't say you must be just one Holsworthy. We said, what do you want to do? And they've said, actually, we'd quite like to have a system that goes across the border, because that population is served by one PCN that goes into Cornwall. So there's no doubt that some guidance, and maybe I'd say to Susie, funding is really important, because one of the drivers of forming One Northern Devon is that we found that One Ilfracombe couldn't survive by itself. Although we had this massive enthusiasm from a bottom up, from a town, we found that actually they needed some support, some help to keep it going, to become sustainable. So if we do not recognise as senior leaders that a bottom up program needs support and nourishing, it will wither on the vine. And that's the danger. But when I heard what Debbie said this morning about the voluntary sector and communities, we have a massive untapped resource that can change people's well-being. But that will require a little bit of support and nourishing from the STP, from the ICS, from DCC, from ourselves, from everybody. So it has been a challenging time, and our continuing battle is looking for funding. And we've got several bids out at the moment for sums like £150,000, without which we will not be able to carry on to the end of the next financial year. So yes and no. We must allow people to have a view and opinion and to be place-based, truly, like Susie was saying.
Sorry, apologies. I'm fortunate enough to have my patio doors open, but it means that the helicopter is making lots of noise. And I think just maybe for us as a CCG governing body, one of the things that we need to look at is whether our LCPs across the patch have a system in place for doing that wider engagement, whether it is a one something or whether it is something else. And I know, John, when you come on to Eastern, it'll be good to hear what is the equivalent that provides the same opportunity in Eastern, and then when we have the others coming through, just making sure that they have those forums for wider engagement. And I think that important thing is, rather than a top-down diktat of what that should look like, us having an expectation that that engagement exists, and then that local determination would be really helpful. And so, John, when we come to Eastern in a moment, if you can just sort of, I'm sure you will go through the slight differences, but with the same ambition that are within your structures there. Judy.
Thank you very much, and well done, John, on all the One Devon stuff and anyone else that's done it with you. Tim, I wanted to ask about workforce, not just for the things we've just been talking about, but for the whole place, the whole system in North Devon. Are there particular challenges recruiting in certain areas? Is retention an issue? Because of course all the various plans will only work if we can get the staff we need. And indeed, we heard earlier this morning about staff shortages in mental health, but we've heard of other plans where recruitment has delayed expenditure. So maybe your group hasn't had a chance to look at this yet, but is that something that's being tackled? And since I will ask the same question about East, you might want to cover both at the same time.
Okay, thank you, Judy. It's a really good question, and I think the strength of local care partnerships is that it obviously does differ from place to place. So I'll give you a high-level assessment, and I think what the ICS tries to do is to do those things at scale that are best done at scale, but allow those things that are best done at place to be done much more locally, and that could be at the neighbourhood level. Like one South Molton, for example, that has just been mentioned, or it could be at an eastern or a northern level, or it could be at a system level. So I think the developing people plan for the Devon ICS system will, for example, in terms of international recruitment of nurses and specialist professions, be the way to go, because it's something that we should do once and once only. And I know that Paul Renshaw and people are working on that. Specifically in relation to North Devon and East Devon, it's the usual pattern of shortages that you'd get across medical areas that anywhere else. I don't think there's any different. I would say, and we're assessing the position, the pandemic will have made a difference here. I would say that previously recruitment difficulties, particularly in the care sector, were less significant in Northern Devon than they were in Eastern Devon, and that was because Eastern Devon was a particularly vibrant economic sector. I think the opportunity that we now have, for example, care, which has been a big issue in the East, has been to tap into those people and to entice them into the care sector. And again, that's a piece of work that is part of our people plan. That was also an issue in North Devon, but less so. So when I look at the waiting times for care packages, much less in the north than it was in the east. So to answer your question, what we ask is a very much bottom-up opportunity. So the best people to support local communities are the people in those local communities themselves, which is why some of the One Northern Devon work focuses on recruiting people much more locally, and our Proud to Care campaign is very much about targeting people in those local communities. So I think the answer is more significant in the east than the north, but I wouldn't want to say there isn't an issue in the north either when around workforce. But you're absolutely right. Money's one factor. The workforce is probably the biggest blockage to delivering on many of these things.
Thank you.
Thanks very much, Tim. I'm going to bring in Susie and Andrew, and then Tim will go to the slide for East, and you can highlight if there are anything specific about East that you want to bring up.
Okay, thank you very much indeed. Well, it's absolutely great, I think, to see the influence that One North Devon is having. And of course, One North Devon and that whole kind of movement has taken quite a while to develop. And it's inevitable, I think, that some of our LCPs will be more advanced than others. So I think our overall approach really has been that there should be differences between different LCPs because they suit the different situations in the 5 different places. There's not a central blueprint for how this should be done. And I think it's notable that the white paper also doesn't have a central blueprint for what place should look like. But what I'm really clear about is that great innovations that are happening in the different places should be spread. So for instance, the high flow work in North Devon, I think is absolutely fantastic. And I think that the way to spread that is to bring those innovators together across the ICS. And that's a piece of work that Darren Halifax is leading on, so that we get sort of contagion by seeing what the results are. But I think there's another thing that we need to put in place, and that is evaluation. Because I was talking to the high flow people a couple of weeks ago, and they were saying that's what they think the next step is, to have evaluation. And I approached Exeter University Medical School about this. And their first response was, well, real evaluation, randomized control trial, is going to cost $500,000. I think we need to have something that's much sort of quicker and dirtier than that, but that nevertheless gives us a sense of what is working and what's having impact, and therefore what it's worth spreading. And I think that as a system is something that we need to give some thought to.
Thank you, Susie. And I think that's a thought process that will hopefully turn into some tangible means of doing it that we'll see developing as part of an ICS. It's an essential part of an ICS, I guess, isn't it? Andrew.
Yeah, thank you, Chair. My point just builds on what Susie's just said, which is was some really thought-provoking comments. In my view, in overseeing engagement for some years now, is the lesson I've learned is you work with what's in local communities. As John said in his yes and no. I think the bit we can do, though, is support them better, make some of the links and connections that perhaps strengthen those groups and how they work. And I see LTPs as being absolutely critical to how we do this better. But the one thing I would encourage, and I've been working with the comms leads in both the NHS and local authorities, is them working together as part of the LTP, I think will enable us to build on the unique strengths that each of those teams has, because local authorities do it really rather well, and I'd want to see us do that at LTP level, because I think it will strengthen what we do with local communities going forward.
Okay. Yeah, thank you, Andrew. Tim, I just to keep us moving, I'm going to put up the slide for East, and then if there's anything particular, a lot of what we've talked about now is just as relevant to East as it is to North, but if there are any particular things you want to raise on East, then please do.
Okay, thank you, Paul. So again, a similar model, as you can see, and perhaps I would just offer an assessment from my opinion. So it's the same model with an executive group, a delivery group and a forum. My assessment would be that the delivery group in the East is better formed, and therefore we have a much more tighter focus on health and care. The less developed bit is the forum, and we've just been talking about engagement, about the kind of excellent work that's happened in One Northern Devon. However, I wouldn't want to give an impression that there is nothing in place. There's been some really rich conversations and groups established as a consequence of what were RD&E-led community conversations. The comms leads at the RD are working very hard to make sure that the various groups in the various market towns are talking to us. So Jeff Chinnup from the RD&E is having conversations with the various groups. Honiton Health Matters, and there are various groups in the towns in Devon, and I think they're the equivalent of the ones, but they're less well developed and they're less cohesive as a group. I think, and I've said this before, because the East is so big and I think struggles with a common identity, unlike the North, I think has a real kind of place-based. I think it's likely that we'll break the Eastern Local Care Partnership down into 3 sub-localities, they being Exeter, Eastern Devon and Mid Devon, and we'll end up with some forums around that. We've had a recent forum, and I think Glynis was there. She may wish to comment at the last meeting. We had an excellent presentation from a voluntary group that is doing some work around mental health and children's services, and it was quite inspiring. And I think that group, that forum, is in development, but probably less well formed and developed than the One Northern Devon model. But I think is on its way, and is absolutely being a bottom-up approach. And building on Andrew's comment, it's building on what exists rather than trying to layer on additional architecture. I guess the other thing that I just wanted to mention in the East and the North really is one of the things we've got there is an award-winning carers hospital service, which won an HSJ award this week and really was a part of that. And one of our Eastern Locality Forum priorities is carers services. So I think there are some good pieces of work coming out of it. I would say that the active engagement of primary care in the East is a real tribute to that system. I think we've got the collaborative board really truly engaged and some fantastic contributions, some network directors. And the other thing I think that East is working towards is an ambition in the autumn, COVID restrictions permitting, to have a kind of conference that brings together the whole of the Eastern sector into a half-day conference. So we're beginning to work up ideas about that. Obviously, they're subject to COVID restrictions. So I'll leave it there, Chair, to allow any further questions on anything I've written around the Eastern report.
Okay, thanks, Tim. Anything particular on the Eastern report that people want to raise? I think a lot of what we discussed north is easily transferable over to the east, isn't it? Tim, I want to thank you. I think those two that articulate the tripartite forums that you've described there are really helpful and give us a real sense of how we can structure things to make the most of the assets and opportunities in each local area. And I can completely understand East being so large and having three distinct identities may influence your forums. Thanks very much, Tim. Thank you for the time putting those together and for coming and presenting to us.
Thank you, everyone. Bye.
Thanks, Tim. We're then on to the committee chair's report. Can I ask that we take the chair's report as read, apart from the finance report, because there is a recommendation from there on the Better Care Fund that governing body need to make a decision on. So chairs of other committees, if you feel that you need to raise something particular, then please just raise your hand, but otherwise we'll take them as read and go straight to Graham, please. Okay, Graham.
Thank you, Chair. A couple of things to say on the finance report. Firstly, in terms of finance, it's the standard report that we've been having for a while about the fact that we're in a temporary financial regime where we're breaking even. John Dowell might want to say more when I've finished about the temporary regime being extended a little further and what might happen after that. So there's a cue, John, for you in a minute. There are two items in the report that I needed to draw to the attention of governing body. The first of those, as you've said, Paul, is a recommendation on the Better Care Fund, and there is this was looked at in detail at the Finance Committee, and there's a clear recommendation that governing body approves the Better Care Fund. And I'm looking at page 3 of my report now, and you'll see there's a little paragraph talking about the changes in the Better Care Fund from last year to this year. Anyone who's read it in detail might wonder why we're bringing it for approval now, given that the Better Care Fund actually started last April, and it's because there was a delay in the guidance from national government. So we'll be signing it almost on the sort of last day of the year that it refers to, but that's where we are. The other issue, and really I was going to draw this to your attention, but I think it's drawn more sharply into focus now by Debbie Francis's excellent contribution this morning and the story of her daughter Jess. And this is about the mental health provider collaborative. We had a report which essentially was for information that we're looking at. The CCG is looking at delegating in shadow form the commissioning of mental health adults and children's services, but also learning disability services to a lead provider in April. And again, on page 3 of my report, you can see the suggestions that were in the report about the benefits that would bring. There's a series of about 6 bullet points there. But the committee went on to just suggest some of the following areas of assurance that it felt it would want to see over the next 12 months whilst this collaborative is in shadow form. And that's a list of 7 bullet points that are at the bottom of my report. And they talk about the governance arrangements, clarification of which services are going to be in the arrangement and those that might be retained, and assurance about the quality of services. What's become glaringly obvious to me during the morning is that amongst those 7 assurances, there is absolutely nothing about patient involvement, carer involvement, working with the voluntary sector. So it might be that governing body would want to add an 8th area of assurance that we'd want to see developed up over the next 12 months. The report also makes it clear that this is only in shadow form and formal approval of the governing body will be required in, say, 12 months' time, and that formal approval will first come through Finance and Performance Committee, but also Quality Assurance Committee. This is a significant issue. I think John Dowell explained to me the other day that it's about 17% of the CCG's budget, something like 300 and something million in total, including learning disabilities as well as mental health. It's clearly the way forward, and the provider collaboratives were very clearly signalled in the white paper, and this is the way that we're going to move. But I think given the excellent talk that we had at the beginning of the meeting this morning, it really does bring into focus the opportunity we have in the next 12 months to focus on mental health services and their improvement. Chair, this was Joe Turl's report originally, and I don't know whether Joe would want to just add to what I've said and clarify anything or not. I'll leave that to you.
I think it'd be helpful to hear from Joe, but the element of with those the concerns that you just articulated, Graham, what the line of sight will be as a CCG during this process to gain assurance on those things that the Finance Committee via Graham's report raised. That would be helpful, please, Joe.
Yes, thank you. And thank you, Graham, for the opportunity to comment as well. I think we had a really good discussion actually at the Finance Committee, which really helped shape the assurance and the work that we need to do between now and potentially getting to the point of moving from a shadow form, which we're going to test over the next 12 months, to that being a kind of a delegated approach, which is obviously the National Direction of Travel as Graham outlined. So I think Graham was right. I think this is a really good opportunity. I think I was obviously listening this morning, and I think what we've got a really good opportunity to do within this is really focus on picking up one of the points that David made in particular about evidence base. And one of the areas that we're looking at, and in fact got a draft document, is around the clinical Senate, which will form part of the provider collaborative. So very much obviously based on the learning that we've already got through the Southwest provider collaborative, which Devon Partnership Trust are the lead provider for. So very much how they run that is through a clinical Senate, which really drives the improvement. And they've drafted a version of that we will want to run in shadow form over the next 12 months. And that will be chaired and run by a lead clinician from across the provider collaborative, bring clinicians together to very much have those discussions about where do we need to focus, what does evidence base say, where do we need to make those improvements, and that will really drive the changes. I think the other opportunity it gives us is really to reduce that variation that we have across Devon as well in terms of our services. So I think that's, bringing those clinicians together to work together collaboratively across Devon, I think is going to really improve our services and particularly reduce some of that unwarranted variation. I agree with the point about patient experience and involvement, and I absolutely think we can add that into the areas that we said we would come back and base our assurance on as part of this. Devon Partnership Trust actually have a process already by which they do that as a provider, but I think as a provider collaborative, we need to understand what that will look like moving forward. In terms of line of sight, Chair, what we will do is we will work on this, and on a regular basis, we will report through to the executive. But in terms of line of sight to governing body, we will at various times throughout the year, we will report back up through the Finance Committee, because obviously there's an implication in terms of performance and budgets, but also we want to report through to the Quality Committee as well to get assurance around quality of services. And I think at that point there, we could probably test that sort of patient engagement opportunity there as well. And that will then, of course, come to governing body for a decision.
So, Chair, just before you bring anyone else in, can we just clarify Joe's point about adding a bullet point about involvement of patients? Let's not forget carers and the voluntary sector generally. So that's either 1 or 3 bullet points, however we word it, but it's those 3 things together. And I know Joe meant to include those.
Yeah, okay. So something about including those who experience the services and that then widens it to something along those lines. And Joe, to incorporate that would be helpful. I'm going to take David's comment. I won't take prolonged discussion on this, but I'll take one comment because I know it'll come back at different phases, and we will have something more tangible in front of us to be able to discuss and consider. But David, for yourself.
So I really just wanted to raise the issue that I raised earlier in the discussion about the fact that decisions made in mental health commissioning, and particularly decisions about how broad the definitions of mental health are, will have an effect on how much we spend on physical services. So there are a lot of people who are frequent attenders at GP surgeries and A&E who use liaison psychiatry services. If there are decisions made about whether those people can access mainstream mental health services, will affect what we spend on services for physical symptoms. In other words, in some ways, I'm really saying that there is an argument against separating the provision and commissioning of mental health services from physical health services.
Okay. I think we certainly don't have the space to explore that, David, but I think that's something, Joe, I think needs to be considered, and let's make sure that we bring that into the discussion as this proposal gets developed further. But David, it does warrant further discussion, but I don't think we can do it justice here at this particular time. Okay. And then Graham, can I ask you then to move on to the recommendation, please?
I don't think there's a lot more to add, Chair. Again, it's summarised there as to how the changes in the BCF are for the last year. The draft agreement is attached. I've no more to add. I would just recommend that the report is agreed and that we sign and seal the BCF for this year.
Okay. Thank you. So I'm going to look for a raise of hands of anyone who needs clarification on this. First of all, Susie.
Thank you. Does the document have anything to say about wage levels? I mean, it may not cover it at all, but bearing in mind the link between poverty, wages and poor health, we shouldn't be entering agreements which envisage people being paid less than the real living wage. And I just wanted to make sure that that was covered.
So it won't be in the Better Care Fund document, Susie, but it is definitely in the agreements that, because we've got a joint contract with Devon County Council for personal care provision, and it's included in there that we will not pay, either one of us will not pay less than living wage.
And it's okay, it's the real living wage, is it?
Let me go back and have a check of that.
Thanks. And so I'm going to we need to approve this as a governing body. It's been recommended and been through that sort of scrutiny process within the Finance Committee. So if we are happy to take their recommendation, then I'm going to go for the lack of hands being a confirmation that we approve that BCF fund. And I see no hands, so let's take that as an approval. Thanks very much. That's the end of our agenda. I did say in my chair's report that I would come back to making Simon feel uncomfortable. It is your last governing body as accountable officer. There is much that I could say. I could say, well, I am going to say, I think you stepped forward as a reluctant hero. He certainly didn't kick people out of the way to claim the accountable officer, but what you did is you stepped into a space that needed occupying and a job that needed to be done, and you have made quite a lot of personal sacrifices in doing so, and they haven't gone unnoticed. I think some of the things, if I was to use words to describe you, I think you're definitely principled. And I think with that comes a significant amount of passion. And that has been of huge value for the CCG to be led through the transition that we went as to coming to single CCG, the pandemic that we faced, but also the need to make commissioning central to what we have to do in Devon as a whole system. I think your focus on making sure we have high quality commissioning, your focus on the culture of the organisation and particularly on the staff has been great. I think you've been brave, you've earned the respect of the wider Devon system. And I have to say, I have thoroughly enjoyed working alongside you as your chair. We have had some very fun times. Doing staff awards in person was definitely more fun than doing it remotely. And actually, you've always tackled even the toughest things with a really good ethos and a really good sense of humour, which chimed very much with the way I like to work. So it has been a pleasure with you as AO. I'm really excited that we carry on working together, albeit in a slightly different way. But I thought it's not just about me saying thank you, and I wasn't going to get 20 odd people to also have their say. So thank you, Andrew. You've primed 3 people to come in and have a few words. So I'd like to ask David Greenwell first on behalf of our clinicians.
Thanks very much. I just really wanted to say thank you for taking on this role. I think we shouldn't underestimate the sacrifice that not just being a leader, but being the leader of an organisation takes on, because everything does eventually drop into your lap. The good, the bad, facing up to the public, facing up to the media. It all ends in your in tray. And I just want to say thank you for taking that on, not as a career move, but as a recognition that it needed doing. So I wanted to say a big thank you from the organisation for being willing to do that. I wanted to say thank you for your style of leadership, which is essentially patient-centred. So whenever you talk about any issue, you always bring us back to what does it feel like for the user of the service, for the patient. And that's always refreshing, particularly from a clinician's point of view when people do that. I wanted to say thank you for being inclusive, for taking on the views of everybody in the organisation before you come to any decisions. And finally, I wanted to say thank you for being calm. It's so easy when all these things are coming at you to lose that inner calmness that enables you to make good decisions. And I wanted to say thank you for being calm in a storm, and we've had a particular storm in the last 12 months. And finally, I wanted to say thank you for keeping clinicians at the centre of all that the CCG does, and really listening to their expertise, not allowing them to make decisions on their own, not allowing them to have any self-interest, but listening to what they're saying about services. So thank you very much, Simon.
Nick Ball for the non-executives.
Thanks, Chair. Well, Simon and I have worked together for a long time now, and Simon, I tried to list all the times you've stepped up into a void when there was a void that needed filling, and I lost count of the number of times, so I'm not going to bother to repeat it now. But the last time you've done it has been the most significant, and you have led the healthcare community in Devon through its greatest ever challenge since the creation of the NHS, you could argue. And you've done it simply brilliantly. And for me, Simon Tapley, when I tried to write down some adjectives to describe you, the first word that came into my mind was genuine. Everything you say, you mean, and you never say something you don't mean. And that is an extraordinary quality to be able to maintain working at the level that you're working at. The second thing I wrote down was fairness. I will never forget very early on in our time together being in a meeting when we were discussing services for people with autism. And it's one of the few times I've seen you get really cross in a meeting, and you were just raging at the inequity of the fact that we've got such horrible wait times for those services in Devon, and that sense of fairness comes across. Everybody in the organisation recognises it, and I think the staff recognise it when you talk to them. And that was the third thing I wanted to say, is that your remarkable ability to remain somebody who thinks about the individuals that work for you is as good as I've ever seen. And I'd like just to take a moment to share with colleagues an example for me, because this for me tells you everything you need to know about Simon Tapley. So this was about 18 months ago. Kathy and I were going up to see our daughter, and we stopped in Exeter Service Station. And as we were walking into Exeter Service Station, Simon was holding a meeting with somebody in the cafe. And as we walked past, I waved to Simon. I said to my wife, "Well, that's Simon Tapley." And we didn't think any more of it. And we went and did some shopping. And a couple of minutes later, Simon came over, walked right up to my wife, put his hand out and said, "Hello, you must be Kathy." Now that to me was just staggering, that in the huge plethora of things that you're bombarded with on a daily basis, you could remember my wife's name and then choose to introduce yourself to her. And that speaks volumes for me about the type of human being you are. And I'd like to thank you for that and for everything you've done for the people of Devon.
Follow that, John Dowell.
Thank you very much, Paul. Simon, I also wrote down some adjectives, but as it's before the watershed, I thought I probably better not use those ones. I'm obviously going to say thanks on behalf of the exec team. I notice that you've turned your camera off, and that's I know why that is, and people have talked a lot about your values, but it's because you care, and we care about you as well. You've led us fantastically as a team. We're an executive team, and it feels like that. And your role as the leader of that team is to pull off that difficult balance of clearly being the leader and the person that has to hold that ultimate responsibility, but also clearly being part of the team. And it's absolutely felt like that. People have talked a lot about your value set. It comes through and shines through very strongly. And what that means for us as a team is that you remind us that we have a huge responsibility and a huge privilege as people who are leading the provision and commissioning of a set of services which have a massive impact on people's lives. And with that responsibility, you don't allow us to get away with being anything other than the best that we can possibly be. And we don't always get that right, but the important thing is that we have to keep trying. And as a leader, you constantly remind us that we need to do that. Throughout this last 12 months, which has been unprecedented, as people say, you have found the time and space and energy and resolve for every one of us in the team at different times to support us and inspire us and to keep us moving forward. And so on behalf of your exec team colleagues, I'm glad you're not going too far, and we look forward to continuing that journey together. Thank you.
Yes, thank you all for being willing to step up and say what you said. Thank you, Simon. I won't make you appear or say anything. I'm going to let us all go and finish this formal public meeting. Let's have 10 minutes. Let's meet up again at 12:10. If we can stay really focused in the private and be done by 1, that will give us a little bit of breathing space before this afternoon session. But let's see everyone back at 12:10. Thank you.